But great, we've got the recording going. Before I introduce him, I have just a couple of announcements. We do like to do these talks twice a month. Our next one is scheduled for October 25th. Michael Pfeffer will be speaking to us. He is our Chief Informatics Officer and Associate Dean for Stanford Health Care in the School of Medicine. Another announcement, SMCI is holding its 3rd annual Excellence in Improvement Publications Review. More details will be available next month in the newsletter, but essentially this is a celebration of all the quality improvement publications that are coming out. A review committee reviews studies that have been submitted, so publications within the last prior calendar year, and gives out a set of awards for that. So that's kind of a fun thing. As someone who was part of a team that won an award last year, we had submitted, a handful of different publications, no idea what would strike the reviewer's fancy, but one of them did. And so that was really exciting to have that happen. So don't be shy about submitting your QI publications. All right, I think that's it for announcements. We do, Selena will put the CME information in the chat. So sign up for that if you need that. So we'll introduce Niraj. Niraj Sehgal is our Chief Medical Officer for Stanford Health Care. He's also a professor of medicine and senior associate dean for clinical affairs in the School of Medicine. He practices at Stanford as a hospitalist, and his research has focused on studying and improving the quality and safety of care, emphasizing interprofessional teamwork, multidisciplinary partnerships, leadership development, and equity. Before coming to Stanford, he spent 16 years at UCSF, where he had a number of leadership roles, most recently the inaugural Chief Quality Officer there. He hails from Chicago, has his undergrad degree from Washington University, med degree from Rush University. He completed a postdoc at the Stanford Prevention Research Center and his MPH from UC Berkeley. So thank you. What a list of accomplishments. Niraj, we're so excited to hear from you today. We'll spend about 30 to 35 minutes hearing from Niraj. Feel free to put your questions in the chat as they come up, and then we'll have some good amount of time for discussion at the end, and we'll aim to end 10 minutes before the top of the hour.
Thanks, Stacy. Appreciate the invitation. Nice to see a lot of familiar names and faces. A few folks who have crossed paths with me in my previous organization who I see on the Zoom, my apologies. A few of the jokes and slides will feel repetitive, so you've heard them already. Part of what's fun here is getting an opportunity both to talk to a group, but also talk about topics that are near and dear to me. I'm definitely an improvement junkie. And so part of what I was going to spend time today talking about is a little bit of just the journey around improvement, less relevant to my specific role today, though I will infuse that in. And as Stacy said, I want to make sure there'll be plenty of time for questions at the end. So I'm going to start by sharing my slides here. And Stacy, just a thumbs up that you can see the slides. Perfect. Terrific. So I've labeled this improvement journey kind of from QI to learning health system. So I finished my clinical training in 2001, which was really the beginning of a lot of the quality improvement journey. So for many of you, I'll share some stories and anecdotes that I hope will resonate from your own improvement journey. And for those of you that have joined the improvement world more recently in the last 5 and 7 years, my hope is it'll also remind you of where we've gone and more importantly, where we can go in the future. So the goals I would say are, what have we learned from our QI journey? And I hope this is a question you will help think through with me as you hear some of the stories I share. And collectively, how do we keep evolving towards the learning health system? And I'll define that using at least one of the definitions. And most importantly, because most of us here are within the Stanford medicine ecosystem, my hope is also you'll help me identify where do you believe we are in this journey? How close are we to becoming a learning health system and beyond? And my hope is you'll think about your local microsystems, but also thinking about where you've seen the organization go and where we hopefully will continue to go going forward. Rather than ending with take-home points, I'm actually going to start with my take-home points. And that's not because I hope you tune out for the next 25 minutes afterwards, but my hope is at least the take-home points will resonate and be reinforced And most of them, I hope, reflective of what you've seen from many of your own leaders in areas as we think about improvement. The first is, I think the ultimate goal is creating a culture for continuous improvement, not simply more improvement projects. And so how do we continue to focus with that broader goal in mind? The second, as I hope will become very obvious, is, and this is independent of pandemic, but I think the pandemic has probably highlighted this even further, is how do we make part of the improvement goal really focusing on our people, not just the data and the tools? And finally, perhaps the most obvious is how do we bring our various system thinking lens and mindset to all the problems that we're encountering on a day-to-day and week-to-week basis. So often when I start talks about quality, I often start with this question, and I'm not going to ask you to put this in the chat, but maybe just take 15 seconds in your head that if I were asking each of you to say, what does high quality care mean to you? What comes to mind? A word, a phrase, a definition. And the reason I start with this question is kind of twofold. The first is that all of you have either been the leader of a quality improvement initiative or the victim of someone else's quality improvement initiative. And most of us have been in the victim role. And so the reason this definition becomes important is because each of you probably put some emphasis on some component of what you define as high quality care. And what that means is that when you watch your colleagues or the organization or your unit or your clinic focus on QI areas, the ones that are going to resonate the most for you are the ones that help fit your definition. When you see initiatives focus on areas that may not be where you put this definition, the change management is going to feel and look differently. So I always try to remind both myself when I go on clinical service and I'm like, this is an interesting initiative. How do we actually think about it differently? And a few of you in the chat, of course, are appropriately putting in where your definitions come from and where our focus should be. The second part of why I think this question is so important is, even if we can all agree upon the definition of it, I think we'd all agree that we're still in a phase where we're still learning better to measure it, right? So part of the challenge is there's so much of what we might describe as being really important definitions of high quality and equitable care, but yet our ability to measure them reliably and help drive improvement is still limited in some places. And so we often are left with different definitions or different external ranking bodies, and we're trying to help improve our performance, but we're not always capturing the things that many of us would describe around truly high quality care. And so that's why I think this question is such an important one, both because of our own individual influences and what influences us in helping make change, but also us as a broader organization. And a number of you in the chat have already put in at least one of the earliest definitions of high quality care. So this is the IOM Quality Chasm report that came out during my last year of residency in 2001. And it organized itself around these 6 aims. And actually, if you look in the chat, I think most of these have been captured. Again, the question here that you might reflect upon is, when you think about whether it's Stanford or whether it's your own experience of being in the clinical and healthcare environment, which of these domains have we put enough attention to, too much attention to, or not enough attention to? Of course, I think 2 of the most obvious that have been highlighted here that are areas we certainly are putting more and more attention to. One is health equity, and the second is just the cost of care across. But these 6 aims, in many ways, if you looked at organization, healthcare systems, organizational scorecards or operating plans back 10, 15 years ago, many of them actually, these were their true north. These were their 6 domains, and they focused in these 6 domains. And many organizations, in fact, still have this as their 6 domain framework. We will come, for those less familiar, at least with the Stanford Health Care domains, I will share those at a later point, but I just wanted to start with this kind of operating model because this is really what began the framework for how we thought about quality in different domains. So this is one of my favorite old slides, and I say old slides. I think that I created the slide in 2001. The PowerPoint version's gotten updated, but the actual content on the slide's the same. And I use this again, part of the historical journey on just what do we mean by QI when that language was being new. And as a reminder, at that time, most of how we captured information about care provided was largely through manual chart abstraction, through paper charts. And I have many recollections of doing those for a number of QI projects, taking loads of charts and looking at post-discharge readmissions and looking through charts to see if we could figure out what actually happened. Obviously, we're in a very different place now, but the premise of a lot of our early QI work was trying to find what we call the quality gap, which is the difference between the care we could be providing with this idea of consistency versus the care that we are providing, which often was highly variable. And I'll give a couple examples here to make to illustrate this point. So one of the first was the door to balloon time. So some may remember this, particularly if you are in the cardiology space or inpatient space, which this is one of the largest national initiatives in QI, which was back in 2006. And the premise of this was taking the evidence that for patients that presented to a hospital with an acute myocardial infarction, if you could get them into the cath lab and open up that blocked vessel within 90 minutes, their clinical outcomes were better. And what came from that was, of course, a large number of quality improvement initiatives across the country with data benchmarking of how you could get from this time, which at least at the time, many hospitals were running 3-4 hours. Actually, hard to imagine that in our current day. But the Pareto chart and root causes of how do you get the team performance to continue to get elevated, which in this case is consistent with actually improving the clinical outcomes. And again, one of those early examples where it was such a powerful way to draw performance improvement and process improvement into actually making really tangible differences for patients. Similarly, as we started learning more and more about how good are we at taking evidence-based practices in prevention, which a number of you touched on in the chat on your definitions of quality, and realizing that 50% of the time we are not providing evidence-based care, particularly around a lot of the primary immunization, cancer screening, and other primary prevention. And I wish we have solved all of that. Of course, we haven't, but another example where we were trying to identify where those gaps are and make improvements. The third example I'm using is a slightly different one, and this is a story I often tell of one of my really close medical school friends who became a general surgeon and started working in a multi-specialty practice. And he and I started getting reconnected at, probably 15 years ago, as both of us were starting to spend more time in this improvement space. And he was a surgeon and he was working in a multi-specialty practice. And one of his observations was in places where maybe there was the absence of evidence-based guidelines, because as most of us know as clinicians, there are places where we don't have great evidence and we're using other tools to help us guide clinical decision-making. He did something that at the time was really novel. And I share the example because I think there's still places and spaces where we could be doing more of this in the spirit of variation reduction as a means and tool to improve the quality of care. And so what he did is he looked at community practice. He had 5 general neurologists, and I apologize for the neurologists on the call. You may have either heard the story or lived this experience. I'm not trying to bring the clinical expertise here. But what he did is he said, I'm going to take all the patients that presented to our neurologist, there were 5 of them in his multi-specialty practice, with a new diagnosis of low back pain. And then what he did is he looked across those 5 providers and said, what percentage of those patients were written or recommended for an MRI of their low back pain after that first visit. So he collected the data, was sitting at a kind of group meeting, a team meeting, and he's presenting the information to the 5 neurologists or his colleagues in the multi-specialty practice. And he's telling the story and said, and as he's starting to show the data, initially de-identified before he presents it, one of the neurologists said, I don't know a neurologist anywhere near here who would not recommend an MRI for low back pain if someone came in. And the neurologist sitting right next to him said, I never order an MRI for low back pain on first visit. And of course, what they started to demonstrate was this unbelievable variation in clinical practice based on the provider you were seeing, not so much based on the patient demographics and elements. So again, a simple example that I think all of us could extend into, in the absence of evidence, how do we think about variation reduction as another tool to think about improving the quality of care? And what I put here at the bottom right was, I think, a tension we still live in, but I think the examples here began to illustrate it, which was the difference between what we might call performance improvement versus quality improvement. So the example I gave with door to balloon time might be a great example where the performance of the healthcare team and a focus on that actually led to improved quality outcomes. We'll use an example that everyone loves, which is the shift over the years around productivity and RVUs. You can make the argument has done a lot for performance improvement, but in certain circumstances has probably come at the expense of improving the quality of care or the experience of patients if they feel like providers are not getting the time they need to take care of patients, and patients feeling like they're not getting the amount of time with providers to work through the issues. So I use the performance versus quality improvement example just because it is a healthy tension we feel. And I'm going to use 2 non-healthcare examples to illustrate this. And this will be the beginning of a few non-healthcare examples I will share, because I have certainly benefited a ton over the years from stepping outside of healthcare to understand what things could be adapted into healthcare. And I'll start with the following example. So I won't ask for show of hands of how many of you have had the pleasure of eating a sandwich at Subway. When I was in my prior organization, there was a Subway that was located very close, so I became a frequenter of it. I got to know the staff and the team there really well. I got to know the leadership really well. And it became one of my learning labs for kind of quality and performance improvement at Subway. And what's interesting is what I learned from the Subway model, which shouldn't surprise any of you who've been to a Subway, is they actually are very data driven. And so what they know when they look at the receipts of when people are coming to use their services, not surprisingly, between about 11:30 and 1 o'clock is their highest time of volume. And so what do? They staff appropriately during that time, right? They have 7 or 8 people, as you see here in the picture, during that 11:30 to 1:30 time, because that's their primary goal, their primary purpose is to get as many people through the line as fast as possible with as many sandwiches produced, right? So they staff knowing that that 2-hour window is their peak time. The other thing they do really well is they have what I would call a lot of standard work. And I could ask you this, and if I was giving away prizes and we were together, for those of you who had the experience, what's the first thing that someone says to you when you walk up to the Subway counter? It is scripted, it is standard. Welcome to Subway, what can I get you? I would like the turkey, 6-inch on cheese. What kind of bread would you like it on, right? And you go through the assembly line with very scripted standard work for process. So what's the downside of that? The performance side is very clear, right? They really focus on trying to get people efficiently through the process. The quality side is when they're really busy, they occasionally will make mistakes. I'm not a big fan of olives. Occasionally they put olives on my sandwich. Now, if they put olives on my sandwich all 5 days that I go there, which is not what my typical practice was, but if I did, I might make a different decision the following week of where I'm going to go get my sandwich. Now, if they put mayonnaise on my sandwich, that might be like a sentinel event because I'm not particularly fond of mayonnaise, and I might not actually eat the sandwich as a result. So the point with Subway is they're making a very intentional decision, which is we are going to focus on performance improvement because we have a primary objective to get as many sandwiches made during the times we reach it. And God forbid, if we end up at a time where we have an unexpected surge of people that come at 4 PM, we get really behind because we're not staffed to do that. And we also recognize at times we're going to make mistakes. And those mistakes sometimes will be olives, sometimes they'll be mayonnaise. Hopefully we won't make them enough where people will stop coming. So let me contrast Subway with another example that many of you have probably experienced. So this is a picture of the runways at San Francisco International Airport. And I might ask all of you, how many of you have experienced a delay at SFO, which means everybody, because if you have not flown in and out of SFO, you know delays are inevitable. So SFO is super interesting, again, having spent time there years ago, on how they balance the performance and quality and safety tension. So I'm pretty confident that fog did not appear in the Bay Area just in the last 40 or 50 years. Yet the design of the runways at SFO are what you see here. They run two sets perpendicular. And by the way, this is not the most updated photo, so there's been some construction around it. But unlike Subway, SFO makes a very different decision around this tension between performance and quality. They make a decision that anytime the visibility, often driven by fog, hits a certain elevation level, 1,500 feet, they shut one of their runways down. So who's happy about that? They have the same performance metrics, right? Flights on time, baggage not getting lost, making connection flights. Every time they shut a runway down, they essentially throw all their performance metrics out the window. But why do they do it? They do it because for them, the cost of the mayonnaise, the olives, or Javier, the cilantro, is too great, right? It's people's lives. If the plane actually is at risk and the passengers and others are involved in a fatal accident, that's not an acceptable risk. So they're making a very different trade-off between performance and quality. So I often end these two examples to say, and not that I'm asking you to answer this in the chat, but when you think about your own clinical environment, the question is, do you function more like Subway or do you function more like SFO? And that is a healthy balance all of us have to muddle through when we are trying to, particularly in the current context, manage our unbelievable capacity and challenges in access and patient demand and volume, recognizing when all of our systems are stretched, we are going to have more human error involved with it. So how do we build systems around it? So I have often found this tension between the quality and performance to be really important and helpful as we recognize what those trade-offs often look like. So what's happened over time? We've, of course, in healthcare, followed many other industries in thinking about how do we do process improvement. And oftentimes we have focused initially quite a bit on tools and process. And the goal here is not to walk through all of these tools and process, because perhaps like many of you, I've also benefited from having gone through a variety of different trainings over the years, whether it's through the IHI model for improvement, Lean, Six Sigma, and all of them at the core, while they use different language, are focusing on these key elements and tools of what problems we're trying to solve. Now, one of the observations in many organizations has been, at times, if we can't create a common language on how we all collectively approach problems, we also disengage many because we make it about the language and not about the tools. And the second element, as I'll touch on with some non-healthcare examples, is what are we ultimately trying to actually accomplish and achieve through all these different improvement processes? Because we're so fortunate here at Stanford Medicine to have so many amazing training programs, and many of the leaders are here on the Zoom because I can see you, who've helped really cultivate this culture here at Stanford Medicine through a variety of the programs to teach many of these tools and skills, to give the experiential opportunities in doing improvement projects. So as an organization, we continue to become, the community of problem solvers that the center certainly aspires to help cultivate. So for a moment, I'll build on some of the non-healthcare examples, and I'm not going to touch on all of them, but just to highlight a few examples that over the years, for me, one of my inflection points when having done a lot of quality improvement work was just how hard it was, and that some of it was not about the tools. It was a lot about the change management and a lot about the culture. And some of those things don't get reflected purely in the tools. And so had opportunities to start spending time in other non-healthcare settings. My brother worked in hospitality. So the bottom left, I started spending time with him at his hotels and restaurants, trying to understand very similar questions. How do they focus on performance metrics? How do they address culture? What are the process improvements they do? I spent quite a bit of time at IDEO, which most of you may know as a design thinking firm that's gotten much more into healthcare the last 10 or 15 years. The Ritz-Carlton and Nordstrom started getting into healthcare as they were focusing on their customer experience and bringing it into the patient experience lens, and spent a few days at each of those organizations, both learning how they do customer service training, but also watching how they were doing training sessions in healthcare systems, what fit, what didn't fit. The two I'll focus on are the top two left. So the one on the left, for those that have had the experience, or if you haven't, I would highly recommend it, is that's the Toyota factory in Lexington, Kentucky. And so as I was trying to learn myself more through earlier lean journeys, I spent a couple of days at the Toyota factory. And while it no question embodied a lot of the incredible tools and process, I think for me, what resonated most from what I learned there was not the tools and process, but was focus on two things. One, an unbelievable focus on culture and focusing on a culture of improvement. And the second, how much of the focus was just on developing people. So while they had beautiful A3s, they had great one-tip instruction guides, they did a lot of cross-training that no one did the same role for longer periods of times. They moved people around to keep people fresh and learning so that when you went into a different role, you could actually get feedback on what was working in process improvement. I think the tools isn't what had me energized. It was really this focus on continuous improvement and focusing on your people. Similarly, I was in a training program for some psychometric assessments and leadership work that I had been doing back about 10 or 12 years ago. And there was a person sitting next to me, and this was not healthcare. So it was a group of folks working across different sectors. And I continue to find that valuable. So my unsolicited advice is, if you have opportunities and this is the work you do, take advantage of getting into other non-healthcare industries, asking some of the same questions, because there's a lot to learn and also a lot to adapt. And so the person who I was sitting next to had a title I'd never heard of. And he said, my title is I'm the Director of Employee Experience at Virgin America, which, as you now know, Virgin America doesn't actually exist anymore, bought over by Alaska. And at the time, it was actually a very novel in air industry, let alone in other places. And I said, so help me understand what you do. Like, what does that actually mean? And he said, well, Niraj, I could explain it to you, but why don't you just come? We have a site in the Bay Area. Come to one of our 2-day employee orientations for all of our new flight attendants. And I said, I would love to do that. We'd be fascinated. Because what I learned at that time was the FAA has lots of regulations, just as healthcare does. And one of the requirements was that in order to go through the training to end up in the flight attendant or other roles on planes, there was a bunch of requirements that were kind of 3 weeks or so of training before you started. Virgin America actually required that 3 weeks to become almost 6. And part of what was striking when going to their initial sessions, because I was asking myself, like, what's going to feel different? What's going to feel different in their training around getting the organization ready? And a lot of it was not about the what. The what was really clear and regulated. It was really the how. It was how they engaged, how they asked their own people to say, listen, our job as the flight attendants is to provide and keep everyone safe. That's the role we want you to play. And yes, there are times where you're going to feel like you're having to police behaviors, but the principle is you're trying to keep people safe. how do you think you can better balance the right behaviors to make people feel safe without making it feel like you're parenting them to say, put your tray tables up or fasten your seatbelt. And to me, again, how they were doing it was more important than the what. It was the engagement. It was actually taking the voice of those that were going to be in the role. And at the time, it was really, again, transformative, not in 2022, but back in 2012, healthcare just wasn't thinking in that way. That wasn't the way we were organizationally oriented and focused. And a number of you are putting in the chat great examples of different roles that now have become much more established in non-healthcare settings. And again, I'm grateful here. We have a chief wellness officer. We have people who are focused, Tate and others, and Brian Bowman and others who brought a lot of that focus to our organization. That's still not happening in uniformity at healthcare systems, but certainly ones here, which I'll touch on in a few minutes. So again, I just want to help us to continue thinking about how important the focus on the workforce really is as the enabler to achieve a lot of our performance metrics. And this in some ways is an interesting microcosm of that journey in healthcare. So I started earlier describing the definition of quality through the 2001 lens of the quality chasm. In 2007, partly promoted by Don Berwick and the IHI, they really tried to popularize this notion of the triple aim: improve population health, improve the quality and care of the patient experience, and do it at a lower cost. And some of you may remember in 2014 was the introduction of the notion of the quadruple aim, where it was the first time they were calling out not just the better outcomes, lower cost, improved patient experience, but the recognition and acknowledgement that if we don't focus some of our time and energy on the improved clinician experience and the teams around those clinicians, we're not going to make headway into helping improve care delivery. And that, again, today feels like, why did it take us so long in healthcare to acknowledge that? And that's how most other organizations are looking at healthcare, that we didn't focus on these things and didn't realize where our potential was as we go forward. And another reminder, I pulled this back in because it's hard not to see this through the lens of the pandemic and what we've experienced the last couple of years. But as a reminder, this was in 2017. And so, if you haven't looked at this, you should Google this report. I'm not giving you the full details here, but this was in 2017, a group of prominent health system CEOs talked, and they focused on physician burnout, but I think it was a broader statement around it being a public health crisis. And this, again, before the pandemic. I think we all recognize how much of this public health crisis remains for our workforce. And two of the elements they really focused on was this idea of calling for healthcare organizations to consistently measure physician well-being. And again, we'll broaden it to healthcare workers from physicians, and making this part of the organizational focus. And I'm grateful the organization I was in and the organization I'm part of now with all of you, this has been the focus. This wasn't actually just in the pandemic. We have been doing this for a much longer period of time, with thanks to many others in the organization that have highlighted it. But this, again, is not the standard in many healthcare organizations, and you're seeing this continuing to grow. So if you go back to that lens and ask, how do healthcare organizations translate their quality down to the tactical and translational operating plan, this is a bit of what you've watched happen across organizations. So I shared that there's still many organizations that orient their kind of operational and plan towards the 6 domains identified by the IOM. Many organizations have certainly pivoted towards thinking about the quadruple aim, the language being different in different places. And I'm really grateful that at least for Stanford Health Care, and I know Packard has something similar, we talk a lot about our Stanford Health Care operating plan across these 4 domains. And in many ways, these 4 domains reflect the quadruple aim, right? So the better outcomes reflected in our quality, safety, and health equity domain. The improved patient experience reflected in our patient experience domain. The engagement and wellness very much focused on not just our improved clinician experience, but the improved experience of our people more broadly. And the financial strength really reflecting our need to be stewards of healthcare costs for societal benefit. And so part of our translation in an annual process at SHC, which I'm certainly happy to answer more questions about during our Q&A session, I just want people to see the connections and dots getting connected, this is really the evolution, not just at SHC, but of many healthcare organizations to say, how do we translate the quadruple aim into our language, into our improvement work, into the way all of you, I hope, see the work you're helping lead in your own microsystems back to these 4 kind of primary pillars and domains. So let me pivot briefly to this concept of the learning health system, because I don't think this will seem particularly provocative because we happen to be in an academic health system. But I think this notion of the learning health system, which in the last several years, I'm giving you one definition from the Agency for Healthcare Research and Quality, which really talks about moving into an environment where we are using data to really drive not just the day-to-day, but the predictive elements of who we are and how we keep improving care over and over again, right? So this is the bottom part of the pyramid you see below, on not just our ability to systematically gather and create evidence based on the care we're providing, helping influence it locally and nationally, but also applying and adapting it really quickly. And again, there's a few of you on the Zoom. I think I saw Steve Ash and others on the Zoom, which, the disciplines over the last 20 years that have grown, we've talked a lot about many of you who built and invested your own time and energy into learning tools and processes and quality improvement. We are an amazing ecosystem at Stanford Medicine with such a deep bench of health service researchers. We also, thanks to Steve and many of his teams in the evaluation science unit, of bringing more of the rigor to the implementation science. And so I share these as overlapping Venn diagrams because part of our unique ability at Stanford Medicine to continue to elevate this is really leveraging the ecosystem we're in to actually make us more and more of a learning health system. And so some of that, and I'm grateful you're getting Mike Pfeffer to come to a future center talk. Mike and I talk about this a lot, is now that we're in a world and living through better ways to leverage our electronic health record data, big data, data science. Nigam Shah now is our inaugural chief data science officer. All the different efforts we have with AI, some of which may in fact be hype and some of which may in fact be ways that help us become more of a learning health system. And so just wanting to keep pushing all of us to realize like these disciplines become so mutually dependent on each other, and ways that we want to keep translating and connecting, which is what one of the goals the center does really well, is building this community of people that sit in these different Venn diagrams, recognizing the goals are the same, and how do we keep advancing and enhancing it. And the last piece on this, I would say, is think about how COVID in many ways has helped accelerate some of this, less from a healthcare perspective, but even from society. There is now early on, think back to those first couple months where whether it was Johns Hopkins, the New York Times, or whatever your source was, that every day you were getting daily amazing data and visualization for what was happening with COVID. We had visualization in the New York Times for what was happening with COVID that we couldn't create in our own building. And in some ways, I think what it was accelerating is this idea of not just a learning health system as a individual health system, but what does this mean as we start thinking about the ability to extend and expand? And my hope is Mike will spend some time talking about the work internally that we're trying to do at Stanford Health, but also as he has his lens through Epic, and Epic itself as a huge enabler for us being able to do this through a lot of our data science and different elements. So again, work that I hope we have a lot of potential for going forward. I don't know if many of you read The Onion. If you're unfamiliar with The Onion, it's one of my favorite sidebar reads. It's kind of the hilarious headlines of different things. I use this just as an example. So this is actually from 2007, which now feels tongue-in-cheek, but this was 2007 at the very beginning of some of what Amazon was beginning to do. And you see the headline here with a little bit of making fun of the creepiness that people were experiencing now almost 15 years ago of, man, how does Amazon know that about me? And for those of you that happen to be Amazon users, of which I am, yesterday I got the Amazon prompt, like, how do they know that I probably need a new pair of running shoes? Because the last time I bought my last pair of running shoes has been a while. Like this is a little bit of their own artificial intelligence and knowing much about us as we do. More recently, this is no longer in The Onion. These are like just news stories, whether it's Google, and you can fill in the blank for different organizations. And I think there's some both opportunity potential here, but also caution that having spent time in some of our community boards, many also concerned a little bit, like if healthcare starts getting into the spaces with AI where we know more about people's health, do people want to know all about that? Is it going to get, are we going to start invading different privacy components? And so I'm not suggesting we are, I'm just pointing out that as we follow what's happening in societal expectations for where other organizations have gone applying data science, artificial intelligence, and in healthcare, we have so much potential for it. These are more like cautionary stories to realize we're going to find ourselves in these spaces as well. And despite the regulatory components that we have in healthcare, I think we also agree in the spirit of the precision medicine, the ability to better identify patients and populations that we can care for in different ways. We need to move into this space. And I would recommend, by the way, reading The Onion. It is a good comedic relief from other day-to-day news that is a fun distraction read. So again, just helping highlight some of where I hope we can continue to move. And so one of my last slides here is a conversation to frame a little bit differently. So we're talking about the learning health system, but part of where I hope we as a delivery system is also thinking more broadly about care transformation. And this is another example where the pandemic has helped highlight some places where we certainly have accelerated goals we may have had 3, 4, 5 years ago, whether that's been in video visits and telehealth, asynchronous care that's created both new challenges, but also opportunities to think about care transformation. This is not, I did not create this diagram, but this is one that I have found super helpful. And when I get opportunities to work with many of you, or if I'm, asking questions of many of our clinical leaders in the clinic or the interventional platform or the hospital, part of what I sometimes try to do in the back of my mind is keep this checklist in mind. And part of what I hope you do as you look at this is to ask yourself, in the clinical environments that you work, where would you rate us? Where would you rate your area in terms of the goal being more towards the right of having a care delivery system that is designed, that's focused on process, that's coordinated, that has standards, that's measure-based, that's one that is learning and improving in the learning health system concept, versus at times, believe me, we all feel much of what we live in the left, right? The left is the firefighting. The left is what we know how to do really well. We can firefight and do crises immensely well in this organization, as I have been taught several times in the last 2 years. But the firefighting is not sustainable. And I think it doesn't allow us to really feel purpose-driven and move into an area where I think we all know we have aspirations to do. And I will say in my role, one of my roles is I want to make sure I'm not being part of the arsonist, which is creating the fires, right? So part of this is also how do we lean into the improvement work and identify and recognize, as the comments coming in the chat, that, Maggie, your comment, I've said this a lot, that, silos not a bad 4-letter word. Like, we need silos. When organizations get large and complex, silos allow us to have affinity groups and affinity areas that make us feel connected to each other and to work we're doing. To your comment, what we need more interactive ecosystems, right? We need places and structures and places where we are doing more of the learning and adapting, so we don't all feel like we're starting from scratch, but actually learning and adapting from one area to the other, which I end at the bottom here talking about the care transformation journey. And, if there are things I could measure, back to my earliest comments about what does high quality care mean and how well do we measure it, I've thought a lot about the last couple of years in particular, that if I could measure in a thoughtful and meaningful way, do we have an engaged organization? Do we have high levels of trust? And do we behave with kindness? I'd like to believe that those 3 vehicles actually allow us to get closer and closer to achieving the left to the right on the slide. And I think, again, the pandemic has brought even more focus and need for us to focus in those areas. And I know many of you are in fact doing that, having gotten to watch many of you present projects and initiatives in different ways. And so I'll end where I started, which was kind of the reinforcement of the take-home points, which my hope is many of you are, again, either leading or, I say, the victim of other people's improvement initiatives, to just keep the eye on the larger prizes, which is doing the individual projects are immensely important. It's what teaches us how to do improvement. The how and how we do it is how culture gets set, how we behave, how we interact with each other, how we foster interprofessional teams, how we think about the different intersections of the different disciplines that we can bring, both from an interdisciplinary perspective, as well as I mentioned, from the health service research, implementation science, just taking the best of what Stanford medicine is. And again, I hope the last 2 bullets are reinforced, which is so much importance to the focus on our people and the systems thinking, and leveraging a lot of the times the painful lessons of our last 2 years to continue accelerating, recognizing we don't know exactly what the next phases of the pandemic will be. We're obviously in a very different phase today, and taking advantage of this time to really continue to transform. So I will stop there, and I will look forward to getting some additional questions and reactions, honestly, for what resonated and what we can collectively do to keep moving the organization forward. So thank you, and I'm going to stop sharing here.
Thank you so much, Niraj. This has just been awesome. I think not everyone's going to unmute, but I'm sure there would be an applause, and I see some virtual applauses in the room. We have already some questions coming in through the chat, so feel free to put them in the chat, and I'll even ask you to unmute. I'm going to take the facilitator's prerogative and ask the first question, because I'm so curious. Taking a 1,000-foot view, which we just did essentially, but asking specifically, how does Stanford compare to its peer organizations? Like, what do you think? What are the areas we're doing the best at? What are we doing the worst at? And what, like, if you could wave a magic wand and just fix something at Stanford Medicine overnight, what would that be, and how can we help you with that?
Yeah, I wish I had a magic wand, Stacy. That would be nice. I think most
Yeah.
embrace that. So it's a fair question and a good question. One of the things I've of course gotten to know two academic health systems, and so the joke is you've seen one academic medical center, you've seen one academic medical center, and I think what I've come to appreciate around that is less about the work, but just more of the structure and the governance of the organization. So I'll give two contrasting examples, which is part of at Stanford, as all of you know, we have many efforts to be more aligned at the Stanford medicine level. And I give a lot of credit to Paul King, David Entwistle, and Lloyd Minor that despite the fact we have three very different entities, right? We have two CEOs who are accountable and report to boards. We have a dean of the School of Medicine who reports to the provost, that the three structures don't actually all line up perfectly at the top. But despite that, three of them have done, I think, a really great job through efforts over the last several years to make it feel more integrated. But those differences in themselves at a governance level are also challenging, right? The university has a certain role and belief on the role Stanford Medicine should play, how big we should be, what the control is. So at a macro level, I think as I'm continuing to appreciate is learning to navigate the ecosystem of a complex academic health system that's part of a broader university can be a big enabler. Like there's elements to leverage that make us who we are. And for me, one of the areas that makes us unique at Stanford, what I love is many of you partner with other parts of the university. It's the design thinking team, it's the engineering areas, it's the business school. Like that's a unique part of what's being here. And I think that's an opportunity for us. I think the other parts, and this is reflected in the chat, is the growing pains. I think I keep reminding people, having left here in 2003 when we were the epitome of a small boutique academic hospital, and now coming back when we are an expansive health system, we're still going through a lot of growing pains. And so with growing pains comes feelings of silos, feelings of, I don't know where to get information. I feel like there's not enough communication about what we're doing. Those are real problems and things that we collectively need to lean into and help to solve. The other, and the spirit of the magic wand, and I would say, Matt put this in the chat because I think he and I have actually had this conversation, and so have I with our performance improvement team. I think one area that I think does make us unique is I'm so grateful to many of you on the call because we've invested as an organization a lot into improvement. This is an example of it. We have a center, we have a number of programs, CELT, RIGHT, ICDP, VBC, CSRP. We have so many programs that have helped cultivate opportunities for people to learn, to be engaged, to build tools. My fear is we've created so many of them and there's so many projects associated that we've cultivated letting 1,000 flowers bloom. And so how do we do it in a more intentional way so that it's not just about cultivating more projects, but what is the singular approach to improvement? Because what I hear from many of the graduates of these various programs, and this came up recently with some of the CELT and RIGHT graduates, is, Niraj, the program was great, but then I go back to my clinical microsystem and I don't see people actually using A3 thinking. I don't hear people asking coaching kata questions. And so one of my hopes for all of you is, how do we as an organization feel like we have a singular approach to improvement, which I think is what Matt's getting at in the chat. So there's a common language, not language that disengages, but actually language that engages people into, this is how we think about solving problems as an organization.
I love that. And that is, we're out there, we're SMCI. We developed the center to bring all of these different communities together and to start having these conversations. This didn't exist 4 years ago. And so I think we're moving in that direction, hopefully. So I'm going to read Steve Ash's question. He talks about evaluation and quality improvement. They certainly go hand in hand towards the goals that we've just talked about. How can we build structures to get them to join hands earlier in the process?
Yes, it's a fair question from Steve. I could actually ask Steve the question in return, because he and I have had this conversation. I'm actually sorry, I'm looking for Steve on my Hollywood Squares. Listen, I think, Steve, you probably have a better depth to seeing where we've done this well. And I think your question embeds where the opportunities are. I guess one lens would be back to the earlier response, which is, as we think about all the different improvement programs, your team in the evaluation science unit has done, I think, a great job of partnering, for example, with the ICB program to say, as departments are choosing some of those key programs, how do we think about evaluation up front? I guess part of what I would love to see us continue to do is, if we can get the 1,000 projects chosen every year down to a more manageable number, it also allows us to do what you're describing more intentionally, which is, what are those large cross-cutting, cross-department, cross-service line initiatives that we think can really move the needle? Then let's take, like the evaluation science unit, and pair them with those groups. So we are asking the questions about evaluation. Right now, it's just not sustainable, right? Every every project presentation ends with the same, this is what we need. We need more project management, we need more data resources, or we need more performance improvement, consultants. And that's a limited resource already. And so how do we actually take advantage of that? That'd be one way. But again, Steve, if you're still on, I'd love to hear your and others' thoughts on how we do that better and better.
And I think Steve messaged me, he's having some challenges with his mic. So if you
No
can,
worries.
Steve, feel free to pipe in, but otherwise don't worry about it.
Can you guys hear me or not?
We can.
Yeah, I am in this group with the Evaluation Sciences Unit all to gather together to hear you speak. You can see us waving our hands here. We appreciate the call out. Yeah, I don't have a brilliant idea as to how to do it, other than I know that it has to be more structurally embedded than it is now. And so I think this is just the beginning, not the end of that conversation. Thank you, Niraj. And sorry about the technical difficulties. Go ahead, Stacey.
And sometimes just reflection on that question, the cross-cutting collaborations that Niraj just mentioned, across departments, across institutions, those are often the hardest and the riskiest, and we like outcomes and we like to see success. So sometimes I think they're put by the wayside just because they're so risky. Just an observation over the last few years. We have a question between LPCH and SHC, what can the two institutions learn from each other? Where are each of them in their own QI journeys? How can we better set that up to learn from each other between the children and the adult side?
Yeah, Stacey, I think there's probably others that can better answer that question, probably understand the Packard side better than I do in the 2 years. I'd say a couple of things. One, again, to my earlier comment, I think the relational bridges between the adult and children's are actually really good, and the center obviously plays a big part of that. Are there ways we could be learning from each other? The answer that's always going to be yes. I think the question is where and how, and where in intentional places to do that more and more. I know both Terry Platchik and Paul Maggio, part of their partnership with the center, have tried to use center venues to even just describe things that we've been touching already, like what's been your approach to engaging the front line? What is your improvement approach? To Steve and the ESU's questions, how do both organizations, the delivery systems, think about their approach to embedding more evaluation into work we're doing? So again, others who may have more vantage points into both. I admit I'm still learning a lot about SHC, let alone what's happening at Packard. But at a relational level, I think there's a lot of desire for that collaboration, and certainly, Denny and London, I spend a lot of time together doing a lot of like, hey, Denny, how are you approaching X or Y at very macro level issues, but also sometimes very tangible pieces that when we're trying to figure out how to help each other.
Yeah, that's great to hear. And you think about those personal relationships, but can we systematize that at each level, the parallel relationships between the adult and children's side?
And the one other piece that I'll just call out there too, back to our earlier examples, is also recognizing, and I say this because you could take this as both a pro and a con, because there's probably trade-offs. The fact that the children's entity and the adult entity are in different instances of EPIC is actually a barrier to some places in this context where we could be doing things similarly differently. And again, I came from a place where it was all a single instance. It had trade-offs. I wouldn't say it was all roses. There were some parts that actually made it easier from the context of data science, from the context of sharing things. It also made it harder, right? Because the needs of the children's enterprise are very different than the adult, particularly the patient population. So again, went back to your opening question of, what's similar or different. Some of these organizational structural components can sometimes be enablers and sometimes can actually be barriers to what people say, why aren't we doing X and Y? And so again, I just use it as a very practical example about where we can really partner and be more intentional. And I think there are examples, like we have a couple steering groups that sit at the Stanford Medicine, right? Things around health equity, things around digital steering, things around different opportunities. So at least the two organizations are not in parallel, making parallel investments when they could be doing it together. And I think that's still a work in progress. So I think trying to understand where those opportunities are.
Great. Katie, well, so Abiduda is hopefully, feel free to correct me if I'm saying your name wrong. Feel free to unmute yourself and make some of the points you want to make. Give them a second. Otherwise, I'll ask Katie's question, and this will be the last one. Any thoughts about the tension between systems, so high level versus local, innovation and opportunities as Stanford continues to grow. So I'm reading the chat. Sorry, I'm not as good at reading and asking questions. So how do we merge and partner to address big problems while also retaining the nimble control over local processes?
Yeah, so again, a really good question and a challenging one to easily solve. So one of the frameworks for me that has been helpful over time, and actually I think this comes from a session I was at with, it was an Amazon session. And so I think this was a Jeff Bezos. So I apologize if you Google this and I'm getting the attribution incorrect, but the framework they used to talk is they used to talk about type A and type B decisions. So type A decisions being an example in our sphere of, we're building a new tower at Redwood City. What should go in that? How are we going to plan for it? What's the impact of it that's going to be lasting over years? That's a type A decision. That should happen slowly, with intention, with lots of the right stakeholder engagement, because the impact of that decision is going to be really longstanding. A type B decision is a decision that should never become a type A decision, which is a type B decision is, I am in clinic A, and in our clinic, we've identified this be one way to help make something better. We should not have to go through 32 governance structures to be able to do that. And we turn a type B decision into a type A decision. And so what I use that example or that framework because oftentimes I'm trying to ask that same question. So when people land with me sharing a problem that I barely understand and asking them to help me understand it, often what I'm trying to do is to ask that, is this a type A or type B decision? Because sometimes we get paralyzed with the type B. And I'm not talking about pilots, I'm talking about things we can still scale and do in a meaningful way. But I think trying to understand that as we get larger and grow more complex, the governance structures we create do make us less nimble for certain things. But I hope it doesn't prevent us, and particularly in this context for a community of improvement problem solvers, how we also keep pushing the envelope, because all of you know this, some of the best ideas don't come from these larger, leadership groups. They come because some area has figured it out. And our job is to say, what did you do? How did you do it? And how can we spread or adapt it to another place? So my hope is we find the right healthy balance between the two, recognizing it's going to be frustrating at times for both, particularly as we do have grown so much.
I love that model. And I was just reflecting back to being a chief resident.
The quick, because I didn't get the misattribution.
Yep. So type 1 and type 2 rather than type A and type B. We did a similar thing in our residency when you're getting those overnight pages with nursing questions. Is this an important decision, or how much time do you need to spend on it versus, what, they can have that extra juice, it's fine, kind of putting every question through a filter before it necessarily making the decision. Thank you so much. We're at time. This has been just awesome. We will see you all next time, October 25th. And with that, we'll say our goodbyes. Thank you, Niraj.
Thanks everyone for joining. Thanks, Stacey, for moderating.